so today we are going to be talking about how to take history in obstetrics and gynecology. So I wanted to make a way that would help you understand, especially if you are in our setup, how exactly we make our own history format. Okay, so the first thing you start with is the date. You write the date, you write the time you are seeing the patient and where we are seeing the patient. So this is the place, so this is for ward 4, and this is the time 11:34. Then you indicate the one, you indicate yourself, you are seeing the patient. This is you seeing the patient, so patient seen. So we first start with demographics. So start with the name, age, marital status, address, religion, tribe, occupation, LMP, gravidity, parity, EGA, which is estimated gestational age, and estimated date of delivery. So we indicate everything. The level of education, and you also ask if the patient is still perceiving fetal movements. Of course, EGA, EDD, still perceiving fetal movements if the patient, of course, is pregnant, because you can't ask if they are perceiving fetal movements if the patient is not pregnant. Okay, so we move on to the presenting complaint. So in asking for the presenting complaint, you have to write the symptoms in the order which they were occurring. So let's say starting of symptoms. So if the first symptom is abdominal pain, write abdominal pain here, say abdominal pain. Okay, then you put the duration. So duration we write, this is how we write duration. So if it's 1 day, we write 1 out of 7. If it's 1 week, we write 1 out of 52. 2 weeks, 2 out of 52. Then if it's a month, we write 1 out of 12. Or if it's 2 months, 2 out of 12. Okay, then if it's hours, we can just say times 3 hours or 3 hours. That's how we write. And then we go to the history of presenting complaint. So the history of presenting complaint, we have the introduction for complaints. You say the patient has been complaining of the above symptoms, then you start the one which first started first. So the patient started with such and such symptoms, which is such and such. So here you ask if there is any pain which is related to any pain related symptom. Don't forget about Socrates. So we ask about the site, onset, character, radiation, association, time, exacerbating factors or driving factors. Then also ask about the effect of symptoms on normal chores. Then others, that's where they even use, if they ask still perceiving movement, that's where they write. They can even ask in the history. So if the patient, of course, these are not the only things you ask. There are some specific things you ask in obs and gyn. For instance, if the patient has come in at 38 weeks, they were draining. So of course, you have to ask draining related symptoms. You ask the patient. Then that's all. Then of course, you have to review of history, review of systems. So review of systems. So CVS. You ask about the chest pain, dyspnea, orthopnea, PND, which is paroxysmal nocturnal dyspnea. You ask about dizziness, fatigability, palpitations. Then the respiratory system, of course, you have to have breathlessness, cough, and you have to find out if the cough is productive or non-productive. And if it's productive, what's the color? Then you also ask about chest pain. Then if it's positive, you also do your Socrates. If it's positive, you have to exhaust the symptom. Then GI in labor, I think that's the most common thing which is complained of. So if the patient comes with abdominal pain, ask about appetite, vomiting, nausea, hematemesis, heartburn, diarrhea, constipation, etc. And the way it is if the patient the presenting complaint was abdominal pain, then in the history of presenting complaint, you have to exhaust the GIT, the system which the patient presented with. You have to exhaust it. So which means when you are reviewing the system, you won't review it. Then others, what I've seen, what they do is they, instead of writing the view of system, they will just ask the patient the symptoms, and they will be indicating no history of chest pain, no history of dyspnea, no history of what. Then they make another bullet, they say no history of breathlessness, no history of cough, no history of chest pain, again another bullet. So that's how they do it. So we go to the next part, which is the GUTs. So ask about dysuria, hematuria, polyuria, nocturia, incontinence, etc. Then CNS, headache, syncope, weakness, paralysis, double vision. Then MSS, so ask about skin rash, joint pain, swelling, joint swelling, zeroing of eyes, hearing of palms. Then that's all in the review of systems. Then if the patient of course is pregnant, you do your current obstetric history. So ask about the gravidity, ask about the parity, ask about the LMP, you ask about the EGA, ask about the EDD. Then antenatal booking, so the date of antenatal booking you have to ask, and at which gestation age, and number of the antenatal visits you have to record, and also have to record the BP on first antenatal visit, and also the booking BP. You ask what was the BP on booking, blood pressure. Were there any complications of pregnancy? What was the prophylactic treatment? So prophylactic treatment, you have fancied, which is of course have to be given. For malaria prophylaxis, you have that, those are the prophylactic treatment. Then you go to your past obstetric history. So you ask about the history of every pregnancy that she has ever had, the place of delivery for every pregnant, mode and duration of labor, birth weight, the breastfeeding and duration for the same babies, and any miscarriage or spontaneous or induced, any MVA done, any post or abortal sepsis, any complications in the puerperium. And the way it is, if someone comes with a prime gravida comes, then of course they don't have any past obstetric history. But some, they don't understand when you tell them, is this your first pregnancy? So you say no, when actually they had another pregnant, but it was a miscarriage, so they don't actually count that pregnancy. So you have to ask them, when you just see prime gravity G1/0, then you want to skip past obstetric history. You can even ask, because it's important, ask if she has any miscarriages before. Even if you are not asking about the past obstetric history, even here you can just ask, just to confirm if she has ever had a miscarriage before. Okay, so we move on to another, which is this part. So we move on to this part, which is the gyne history. So ask about the gyne history, age of menarche, regularity of menses, the duration of menses, any dysmenorrhea, contraceptive use, duration, age of sex debut, number of partners, any STIs, spouse circumcision status, any pap smear or VIA, and when exactly were they done. So you ask if the patient has had been screened for cervical cancer. Okay, then you go to past medical history. This is past medical history: DM, epilepsy, asthma, TB, hypertension, SCD, RVD status. What's the RVD status of the patient? History of similar illness in the past, any hospital admissions in the past, history of hospital admissions, any other illnesses in the past. You ask. Then past surgical history, you have to ask, this is past surgical history, you have to ask when, why, where. So you go to drug history, you ask about the drugs being taken, any herbs being taken, any allergies, any side effects noted. Then you go to family history, you ask for the marital status, social habits, smoking, alcohol, occupation, number of occupants, sanitation methods, use of ITNs. Then if you are clicking in the words, if you are in OPD, there's no need for summary of history. You write your important positives and important negatives. And for example, this is how you summarize. In summary, EM, female 23, John Parazero, 34 weeks, self-referral from home, who presented with spontaneous onset of progressive suprapubic pain, which started 8 hours prior. Then the pain is associated with lower back pain. Then there is no history of dysuria, fever, and hematuria. Then, if you are done with the summary, of course you have to do an impression from history, your differential diagnosis from history. Then on examination, you do a general condition. Is the patient conscious or unconscious? Are they stable? A febrile or febrile? Your para, jaundice, cyanosis, you check. Then your respiratory system, when you examination, most people find they write this one is to normal, but that's after you actually examine. On inspection, palpation, percussion, or auscultation, then after you've done your findings, then that's when you can write what are your findings. Is there echo air entry? Are there vesicular breath sound? What is the sound that you have actually not noticed? Then you go to CVS, same inspection, you palpate, you auscultate, because that's how it is. So you have to read up on the examination. You have to know how to examine patients. Then even here, you have to know how to do your obstetric examination. So per abdomen, you have to know the symphysiofundoid. You have to know the presentation. So you have to know your abdominal examination, so to say. So when you are doing your per abdomen in history, bearing in mind that you already know your per abdomen examination, obstetric examination. So you have to take note of the symphysiofundoid, presentation, a number of stations, light, descent, adequacy of liquor volume, fetal heart sound. Is the fetal heart sound regular? Is the fetal heart sound tachycardic? Then you have to actually take note in 1 minute, because the fetal heart sound, if it's irregular, then you count, let's say you make it enough, 30 seconds, then you find that it's 75, then you multiply by 2, it gives you 150, then you say it's normal. But then again, someone finishes for 1 minute, you find that they count for maybe 100, because it's irregular and it's not following the same pattern. So you can't cut that you just count in 30 seconds, then you multiply by 2. No, you have to finish in 1 minute. Then of course, if the patient is pregnant, you can note for the linea nigra. Then after you've done your per abdomen, you can do your VE. So not all patients require VE. For example, those patients you are suspecting, let's say from your impression from history, you are suspecting APH. So we know that patients from APH, you have to be careful, and patients for PROM, you have to be careful. So you don't just do VE on any patient. So you have to know why you're doing VE and if it's actually indicated. But in most patients who present with gynecological conditions or obstetric condition, of course can do. So the things you note for, if there are invisible sores or what's on vulva, invisible vaginal discharge, PVB, VV. So if the vulva and the vagina are normal, that's how people indicate V/V normal. And if it's in obstetrical, after you have to also know the cervix, the condition of the cervix. Is it moist? Is it soft, firm, hard? Then are there any cervical excitation or tenderness? You have to note. Then if it's of course an obstetric condition, the woman is in labor, you have to note the os at which dilatation. So you have to know the centimeters, at what centimeters. So contractions, are they mild, moderate, or strong? So you have to indicate and how many. And then MSS, of course, you have to note for any edema or retinopathy. You also have to grade and you go to the urinalysis. So you have to do urinalysis, or if they were from doing it, then just write the results. So these are the things you have to take note of. Then again, if you are clicking from the words you are learning, you can summarize summary of history and physical examination, important negatives and important positives. Then your final impression, you write one. You write your impression, then your differential diagnosis you include. Then the last thing you can write is your plan. That's for set up your plan. Sometimes we mix our investigations and our treatment. So we say if it's one, we are giving folic acid. Say one folic acid, two FBC, three LFT. That's how we do it. Four BP profile. So your plan is comprised of investigations and your treatment. But the others who separate investigations, then the right one they investigate, the treatment they write their treatment again. But that's the end of the tutorial. This is the end, but